Welcome to everybody. We're very delighted to be presenting this lecture from the StrokeEd collaboration. I'm Simone Dorsch. I'm one of the StrokeEd directors. And this evening we have, well, people from all around the world listening to Amanda's lecture. So welcome to everybody. Just some housekeeping to start with. If you have questions during the lecture, can you please use the Q&A function? And Amanda will pause at about 3 or 4 spots through the lecture to stop and answer any questions. So please use the Q&A rather than the chat, and you don't need to raise your hand because we can see that you are putting things into the Q&A. Anyway, so we'll get started. So I'm very, very thrilled to welcome Amanda Baker. Amanda is an advanced physiotherapist working at the Sunshine Coast Hospital and Health Service. She has many years of experience working in rehabilitation in Queensland, and we're really looking forward to this lecture from Amanda. She's going to tell us how she comes to be presenting this topic. So I'll hand over to Amanda.
Thank you for the introduction, Simone, and thank you for the opportunity to present today. As Simone mentioned, I'm here today to present on goal setting in rehabilitation, and specifically the why and how we goal set in rehabilitation. I'm actually currently conducting my PhD in this topic, and alongside this, I've also recently led a project within the Queensland Rehab Clinical Network to implement best practice goal setting in 5 rehab services. So I'll reference some of the content and learnings from that project as we go through today, and I'll also provide some links to the resources that we have towards the end. So firstly, I'd like to begin by acknowledging the traditional owners of the land from where I am presenting today, the Gubbi Gubbi people, and to pay respects to the elders past, present, and future. As an overview for today, we're going to cover some goal setting terminology, recommendations and evidence for goal setting, why we goal set in rehab and how to goal set in rehab. We'll also cover off on some goal setting frameworks and tools, and briefly describe some common barriers and enablers to implementing goal setting in rehab settings, and some possible strategies that you might be able to use to enhance your goal setting practice. Now, there's a lot to cover, so it will really just be an overview, and I'll endeavour to provide you with references and some resources that you can take away from today to continue to develop your goal setting skills. So I'm hoping mostly that from today, people will be able to walk away with an increased understanding of why we use goal setting in rehab and how goal setting can enhance people's outcomes and autonomy. I'm hoping you'll also be able to walk away understanding a comprehensive framework for goal setting that can be used across the rehab journey and in any rehab setting, and also be able to be aware of some of the common barriers and enablers that you might face when you're trying to implement goal setting, either as a rehab clinician or within a rehab team. So firstly, I'm going to start off by highlighting some common terminology and definitions. One of the most common barriers we've found in some of our research is the mistakes clinicians make in misinterpreting the use of goals and actions. So it might seem somewhat basic, but I'm going to highlight the definitions here from the literature that we'll use for this lecture. So William Livack and colleagues out of New Zealand have described a rehab goal as a desired future state to be achieved by a person with a disability as a result of rehab activities. Rehab goals should be actively selected, intentionally created, and have purpose and are shared wherever possible by people participating in those activities. So the key here is that a goal is actually a future state. It's not something you can already do. It's something you hope to be able to do in the future. Secondly, we'll highlight the term goal setting. Now, often goal setting is commonly used purely to represent the selection of goals. However, for the purpose of this lecture and in keeping with the literature, when we use the term goal setting, I'll be referring to the entire goal setting process and all the components involved in goal setting and goal pursuit. That then brings us to the final term I wanted to highlight before we get started, and that's the term goal pursuit itself. So when we use this term, I'm really using this term to refer to goal-related activities, such as developing action plans, coping plans, feedback, and review. So this is all the things that encompass a holistic goal-setting process. So now we've got a clear definition for a goal and goal setting. We'll look at the current recommendations. So goal setting is recommended in many national and international guidelines, and our own Australian Stroke Foundation guidelines have a strong recommendation for implementing goal setting that involves stroke survivor, is person-centered, clearly communicated and documented so that all team members are aware of what goals are set. They also recommend that goal setting should be done in collaboration with the stroke survivor and their family, and goals need to be well-defined, specific and challenging, and they also should be reviewed and updated regularly. So when we look at the effectiveness of goal setting in rehabilitation, William Levac and colleagues actually conducted a Cochrane review in 2015. And what they found was that goal setting can increase a person's self-efficacy or their confidence when compared to no goal setting. Goal setting can also lead to increases in health-related quality of life when compared to no goal setting. And they also found that people had an increased satisfaction when they were using structured approaches to goal setting rather than unstructured approaches. And finally, they did highlight one study that showed a small effect size in several components in favour of setting more specific goals than non-specific goals. And that was seen to improve people's outcomes. Now, there are many challenges in developing high quality goal setting research due to the difficulty in designing strong RCTs. So given the challenges in designing this kind of research in rehab settings, there has been limited evidence that goal setting alone can impact activity and participation level outcomes for people. So it's important we really understand how goal setting might impact a person's outcome so we can ensure we are maximising the key elements of goal setting practice. Now, I imagine many of you already understand that goal setting is an important part of rehab. But what I really want to challenge you to have a think about now is take a few steps back and ask yourself why you goal set in rehab. Why do you use goal setting as an intervention in rehab? I'd like to play a short video for you now that was developed by the Sunshine Coast University Hospital rehab participants and highlights the importance of goal setting from their perspective. So take a bit of a time now to think about why you goal set and have a listen to some of our rehab participants.
Goals are often a word that people are fearful of. I've always been a goal setter in my fitness, in my life, but I looked at it more, even if you don't want to call it a goal, call it something you maybe want to achieve, even a small achievement. It doesn't have to be something massive, and my small achievement was actually to stop crying, because I cried a lot. I cried something sad, happy, my emotions were all over the place.
One of my main goals obviously was to get my independence back, to be able to look after myself, toilet myself, brush my own teeth, scratch my nose, those little things, you know, because I couldn't do any of that. So that was those little things were my main focus. But in the big picture, prosthetics was what I really was pushing towards, getting in the prosthetics and getting around up on my legs again. So, you know, and beyond that, I've got a big range of goals. You know, I want to get back in the car and drive around again, and I used to surf. I used to surf and fish, so I'd love to get back out there and do that again. So that's what's driving me on with my arms, as well as the prosthetics, is to just keep pushing forward.
Cooking was a really important goal for Amos because he has always loved to cook. When he had his stroke, he actually said to me in hospital, I don't think I'm going to be able to cook anymore. We'll just have TV dinners when we get home. And I thought, no, absolutely not. We were not going to let him give up his passion. So he worked really hard, and that's why it was one of the goals, so that he could still continue to do that when he got out of hospital. It was such an important part of his life before, and we didn't want him just giving up on that. So he is so happy to be able to cook again now. He loves doing it, and he cooks every night, but he also cooks every week for a family dinner. It takes him a lot longer because he still has to have modified ways of doing things, but he gets that sense of achievement from still being able to do what he loves most.
Break it up to little bits. That ball, then this ball becomes a cricket ball, and the cricket ball becomes something else, so it goes up.
My goal for me was actually to publish my book. That was however long that would take, and I achieved that within a couple of years, and my goals now are still managing my fatigue 5 years later, but if you do it in baby steps and in small chunks and just look at them as little achievements instead of huge goals.
You've definitely got to have goals and something to work towards, a target, and and also, you know, at home I've got 2 young kids and a beautiful wife, so getting back into the family was a big driver as well. There is a lot of small goals you've got to aim towards, because if all you do is focus on the goal at the end, it's just a little bit overwhelming.
The important thing is, if you don't get to that goal or you don't achieve it by the time that you'd planned to achieve it, just don't give up, just keep trying again, just rehash the goal, or perhaps think of it in a different way.
Definitely got to have goals. Without goals, you might lose focus a bit, especially if you've got a big journey ahead of you.
Part of it is celebrating the goals and the achievements with whoever's around, you know, your family, your friends, and make a big thing about it, because your goal could be something as moving your fingers, moving your toes, being able to move your mouth again, you know, in any form of rehab. So celebrate them however small or large they are, I would certainly say to people.
So I hope you've all taken a little bit of time to reflect on why you use goal setting in rehab. You can see from the video that some of the important aspects of goal setting to people receiving rehab include using goal setting to be able to celebrate success, being able to learn from it and actually be able to try again, but also making sure that goal setting is about what's important to them. They've also highlighted that we should be able to ensure dream goals are included, but there are small steps towards those that help keep people focused during their rehab. So what does the...
Oh, sorry,
yeah.
Amanda, sorry to interrupt.
Yep.
Can you close the control panel at the top? Do you know if you go to those dots, it just
Yeah.
sometimes it covers the title from our view of
Right.
it. So can you see that? So yeah, yes, it is in there. Where it says hide floating meeting controls.
Hide.
Okay. Yeah. That. Oh.
Apologies.
Yeah.
Okay. So we'll now just have a bit of a look at what the literature actually tells us about why we goal set in rehab, and what are the important mechanisms, and how can we actually achieve that in rehabilitation. So through a recent program of research that we've conducted through the Queensland Statewide Rehab Network, and alongside researchers from Griffith and Monash University, we built on some work from William Levac and colleagues, and have collated the current evidence and developed a conceptual framework to review the purposes for goal setting in rehab, how we can achieve those purposes, and what we can do to enhance the process. Now, I know this table is very busy and it's difficult to read, so for the purposes of this presentation, we'll just focus on how goal setting can improve a person's performance and how it can enhance their autonomy. If you're interested, you can find the full version of the table and article published online through the Journal of Disability and Rehab. So if we go to just looking at how goal setting can improve a person's performance or their autonomy, it can achieve these things through promoting interdisciplinary team working, by motivating both rehab participants and clinicians, by enhancing the specificity of treatment programs, and secondary therapeutic benefits such as enhanced self-awareness or self-efficacy can be achieved through goal setting, and this can in turn improve a person's performance and autonomy. And then finally, person-centered goal setting can also increase a person's ownership and enhance their autonomy throughout the rehab process. So then we ask ourselves, well, what do we as clinicians and rehab teams, how can we actually enhance these mechanisms? How do we have interdisciplinary team working? How do we motivate people? How do we give people ownership? Key elements of interdisciplinary team working include having a common goal focus, ensuring the team are communicating regularly, including the person receiving care as a member of the team, and ensuring that rehab teams have high functioning. In order to motivate people, however, we should be ensuring that goals are meaningful to the individual, that they're specific and challenging, that we use positive goal statements, and we include both short and long-term goals. We must also ensure that we're including specific staff and individual action plans. And where barriers are identified to completing action plans, we should make sure we're trying to set up a backup plan or a coping plan to help make sure those actions can be completed. Including elements of measurement, feedback, and review can enhance the secondary therapeutic benefits of goal setting, such as increasing self-awareness. And including principles of shared decision-making can enhance an individual's ownership over their rehab process. To implement shared decision-making, though, we must also consider that the personal factors that impact participation in shared decision-making, and also the clinician's skills they have to engage people in the process. So we're going to talk through each of these sections in slightly more detail now. So team working, we know, is a core component in rehab, and it's a really pivotal in the goal setting process. There are generally 3 types of team working that have been identified in the rehab literature, and these include interdisciplinary team working, multidisciplinary team working, and transdisciplinary team working. Firstly, interdisciplinary teams are groups of diverse professionals. They constitute a team and they communicate regularly and use their expertise to work towards common goals. However, a multidisciplinary team are a group of diverse professionals, but often the regular communication and common goal orientation with these teams is less consistent. Finally, you'll also see transdisciplinary team working often in rural and remote settings. And this is where team members share their skills between disciplines, so they have blurred boundaries and they share responsibilities across the team. So when we're looking at the types of team working here and we're focusing on interdisciplinary team working, the key here is that an interdisciplinary team have a common goal focus and communicate regularly. And we should really be looking at the person's goals as the common goal focus among the team. So further to having a common goal focus, an interdisciplinary team really needs to consider the person receiving care as a member of the team. This kind of interdisciplinary team working has actually been shown to have improved outcomes for stroke survivors when compared to multidisciplinary teams. And making sure you have the person's goals considered the common goals, then you've got multiple team members using their varied skills to strive towards the same outcome. And this has the potential to improve the reinforcement that you can have in a rehab setting, and ensure that actions are undertaken which will enhance goal pursuit. In a recent study that we're about to publish in Queensland, we aim to increase all of the key elements of best practice goal setting in 5 rehab services. And some of our preliminary findings suggest that teams improving the most in developing a common goal focus were also teams that improved in all other aspects of their goal setting practice. So it's really a core element. Aspects of team functioning are also really important, and this can actually lead to improved people's outcomes in rehabilitation as well. A series of studies by Dale Strasser and colleagues in the US found that actually increased physician engagement in a team led to overall a decreased length of stay for rehabilitation clients, whilst increased teamness and team effectiveness were found to increase the proportion of patients discharged home to community. In this study, teamness refers to how well the team worked together, whilst team effectiveness refers to how well individual team members perform their work. And what we also know then is team training itself can improve team functioning in rehab teams. So these are all ways we can enhance that interdisciplinary team working. So in summary, to enhance aspects of interdisciplinary team working that can improve a person's performance and autonomy, we should ensure that rehab teams have a high level of team functioning, working towards common goals, they're communicating regularly, and they include the person as a member of the team. Now, for the following areas, I'm going to present a holistic framework that'll support you all to be able to implement the remaining key elements of goal setting in clinical practice. But before I move on, Simone, I just wanted to check if there's any questions or anything so far that I could answer.
No questions, Amanda.
Great, thank you. So the one specific framework that I'm going to highlight and use throughout the presentation today is called the Goal Setting and Action Planning Framework, or GAP, as it's sometimes more commonly known. This framework actually summarizes a really holistic goal setting process, and it's relevant for both inpatient and community rehab settings, and it can also work in any rehab context and with any rehab population. The Goal Setting and Action Planning Framework was actually established by Leslie Scobie and colleagues out of the UK in 2011, and they based it on several theoretically informed psychological theories. So these theories underpin the GAP framework, and it's 4 stages. So the first stage of the GAP framework is a goal negotiation and goal setting phase. The second stage includes a period of action and coping planning. The third stage involves taking action, and then the final stage involves appraising those actions, providing feedback, and reviewing goal progress. So we'll use this framework to talk through the rest of the lecture. So starting with the goal negotiation phase, this is really where you should be spending some time talking with the person and their family about what their main concerns are and what their overall goal areas may be. In this stage, you're trying to identify what's important to an individual and any of those longer term dream goals that people are wanting to achieve. Goals in this phase don't need to be smart. We'll talk about setting specific goals moving forward. You need to really take time to listen in this phase, and goal areas really need to be based on the person's priorities and preferences, and they should be agreed on by everyone involved. So a key component in effective goal negotiation is shared decision making. So things to consider and be mindful of during shared decision making include ensuring that you're exploring a person's values and beliefs, and make sure you explicitly promote shared decision making. Tell people this is what we're actually going to try and achieve here. You can use motivational interviewing skills, and you can provide opportunities for people to develop self-efficacy or confidence and show them what they can achieve rather than focusing on the things they can't do. You may need to consider a person's communication and cognitive abilities here, and you might need to consider how you're going to tailor your goal negotiation interaction to maximize their participation. Now, when you're starting a shared decision-making goal negotiation session, there's a few things to keep in mind, and probably the first and foremost thing you need to keep in mind is whose goals are you actually there to set. I'm going to play you just this short clip from the Agency of Clinical Innovation, where Stephanie outlines some of her experiences of goal setting in her rehab journey.
In my rehab goals, I don't think my parents never really got the chance to be actively involved in the goals. I was to an extent. I would say things like, I want this to be my goal, and then I would be gently reminded that no, this is not really a good goal for me, for you, even though really that's what I wanted to do. So I got the chance, but I never got to the chance to at least try that goal. The goals I had would usually be things like very practical, functional goals, like tie my hair back or topping to make a meal, like writing again. So albeit I was very affected and at that acute stage of my life, that was not really possible, but at least, you know, give me a go. I just wished they give me that chance, because I think it's better than to not.
So we also actually have some evidence that backs up Stephanie's experience that you can see here. So evidence suggests that clinicians do prioritise their own goals in rehab settings. One review actually explored how clinicians control the process of goal setting, basically to meet perceived professional responsibilities. And they found that clinicians prioritise certain types of privileged goals. Privileged goals shared several characteristics: an orientation towards physical functioning, short timeframes, and conservative estimates of progress. And they identified also several reasons that clinicians do this, and that includes feeling an obligation to set goals that align with service expectations rather than patient preferences, having an obligation to achieve goals in certain timeframes. And clinicians were also concerned about including goals that disagreed with their perceptions of what they thought the person could achieve. And then they were worried, obviously, again, about setting people up for failure. But what we see here and what we have seen in the literature is that people have reported that they really want to keep that dream goal included in their rehab. And sometimes even if that goal isn't necessarily achievable, they can still be motivated by the dream. People have actually said that they report keeping goals secret if they don't feel that the clinician will actually deem these appropriate. So really, we shouldn't be taking away these dream goals, but finding ways of breaking the goals down into smaller steps to help people work towards those goals. It's also really important to keep that dream goal setting if you consider that you're using goal setting to motivate someone and achieve a higher level outcome. So make sure you're always keeping in mind why you're using goal setting, because those dream goals are what might motivate a person. Shared decision-making skills aren't easy. They're not simple, and it takes time to learn and consistent reflection and feedback and practice to be able to implement them well. Evidence for this was published by Lisa Cameron and colleagues, where they reviewed clinicians' understanding of shared decision-making skills through focus groups. Clinicians did demonstrate they had knowledge of shared decision-making principles, things such as showing respect and building rapport, asking and listening, and responding to people's immediate needs. However, when the research team then observed those clinicians undertaking their assessments and treatment sessions, they observed that most clinicians were not actually able to implement those skills. So this really highlights the difference between knowledge and skills. So we might know what we need to do, but actually putting it into practice can be more challenging. And I mean, I'm talking to a lot of physios and OTs tonight, occupational therapists. So I'm sure you all understand that learning skills actually requires practice. So what I would suggest when you're working on enhancing your shared decision-making skills is that you think about those opportunities you have to practice, use video or audio recording to help you self-reflect, maybe consider some peer observation sessions, but also ask people for feedback. And that doesn't have to be in a formal survey. That can be as simple as at the end of a session, asking the person, how did you think that session went today? Do you think we've accurately captured your goals and needs? Or do you have any feedback for me on how I could conduct these conversations better next time? This is especially important when you're starting to develop rapport as well. So other tips to help you in shared decision-making or goal negotiation: when you're trying to engage people in shared decision-making, make sure that you're taking the time to build a trusting relationship and understand the person's history. Do explain your role, but just make sure you don't narrow the focus of the session to things only relevant to you and your role, as this is about the person that's in front of you. Be responsive to the person and the family member's needs, and ask people and their families what it is that they're wanting to focus on. Focus on meaningful occupations and interests as a starting point. Make sure you really don't forget some of the really simple things that can really change the process enormously. Making sure people have their hearing aids and their glasses. Simple things like making sure you have a pen and paper, and knowing how that person communicates best. And make sure your environment is communication accessible. Is there enough lighting? Is there too much noise? Have you got appropriate seating? Can you sit across or beside the person? And do allow a bit of extra time for those people who have communication difficulties It will take a little bit more time, and that's okay. One of the key strategies to promote people's engagement in goal setting is education. So numerous research papers have actually found that people report feeling underprepared for goal setting interactions due to the amount of information, or lack of information, and knowledge of how, what, or even if they should contribute. So I think it's really important that we're clear with the people that we're working with, and we actually give them permission and tell them that we want to hear from them. This is a process we want them participating and leading in. Education is a key element, and it may include things such as educating the person on what has happened to them, what rehab is, what a goal is, and why they need rehab. We have seen several studies that actually have found that giving clear information about a condition can lead to improved goal setting, and people who are more involved in the goal setting process actually have greater improvements in their function. I was supported during the project I've recently led by the statewide Rehab Clinical Network here in Queensland to develop a goal setting workbook to help guide rehab participants and team members through the goal setting process. So the resource includes information about what rehab is, why they might need rehab, and it is actually structured using this goal setting and action planning framework. So it provides clinicians with a framework for having the goal setting discussions. It's recommended that the resource is discussed with the person by a member of the rehab team as well. And this is available online, and I'll provide the links later on in the presentation. It's also been designed to be customised and tailorable to different services. So some other communication strategies that you might like to use in your goal negotiation phase come from a paper that was published by Kate de Cruz and colleagues out of Melbourne. They actually looked at the engagement of people with severe acquired brain injury and their families in goal setting practice. And they found that directly asking a person, what is your goal, was actually not the most effective way of eliciting meaningful goals. They actually found rather different questioning strategies, such as what is important to you, what occupations do you enjoy, what does a day look like for you when you're home. These kind of questioning strategies were more effective at actually eliciting relevant goals. So finally, one of the common barriers that clinicians face is when they can't understand or communicate with a person. So it's really important that you make sure you continue to address the person directly. Don't turn your back and talk to a family member without continuing to address that person. You can, though, ask a family member or friend if they can help advocate and help you communicate. And make sure you acknowledge the difficulty and share the responsibility. I'm sorry, John, I'm having a bit of trouble understanding what you're trying to say. This will just help clear the air and help the conversation move forward. You can also try recapping the discussion and using strategies such as, so what I'm hearing is that correct? Use a pen and paper. It's really good to provide keywords at times and sometimes some visual pictures to help communicate. And if you're really struggling, you can suggest coming back later and seeking further support if necessary from a speech pathologist or family input. So in summary, it's within the goal negotiation phase that clinicians should be focusing on creating a shared decision-making environment and seeking to understand what's important to an individual. Moving on to the goal setting phase, goals set in rehabilitation should be meaningful, specific and challenging. There should be positive goal statements, and there should be short and long-term goals included. So this brings us to SMART goal setting. So I'm sure many of you have heard of and potentially use it currently in your rehab practice. While SMART goal setting acronym goes some way to support us to set a specific goal, the one area at odds with the perspectives of people receiving care is the concept of setting an achievable goal. And we've talked about this a little bit already. As we've discussed, in some instances, you'll want to ensure goals are achievable to help develop confidence in an individual in what they can achieve. However, in other instances, if you're wanting to motivate people, goals should be allowed to be dream goals and be centered on what inspires the individual. There is no right or wrong answer specifically, but you need to know why you're goal setting. And unfortunately, the SMART acronym itself does not tell us how to set a specific goal. So a paper published in 2008 in Clin Rehab did outline some steps to setting SMART goals. And these aspects include including information about the context or the environment of where the goal's to be performed, how well the goal needs to be performed and what level of supervision or support one needs, what's the quantity or how much of the goal needs to be performed, and also including an estimate of a time frame or how long you think it will take to achieve the goal. It's also really important that we use positive goal statements. So how do you allow and ensure meaningful and specific goals, short and long-term goals, in your practice? The International Classification of Functioning Disability and Health, or as it's more commonly known, the ICF, is useful to assist in framing the steps to recovery and can support you to follow an evidence-based approach to clinical reasoning. The ICF evaluates a person's health condition in relation to their body function and structures, activity and participation limitations, and includes consideration of one's environmental and personal factors. So long-term goals or dream goals are usually things at a participation level of the ICF, such as returning home to be a mother to my children. Participation level goals should focus on people's roles and dreams. And at the activity level, you can then consider the specific activities that someone needs to be able to do to achieve those goals, such as being able to get up and shower yourself each day. Now, there's some overlap in participation and activity levels, and they're not always defined as one category or the other. There are actually 9 categories of ICF activity and participation levels that they've defined. And you'll see some of them lend themselves more to activity levels, such as mobility and self-care, while some include more participation level goals like community life and major life areas. Once you've decided on your activity level goals, it's important to analyse the person trying to perform the activity, and then you can break down the specific reasons they're not able to perform those activities. And these are usually your body function and structure issues, such as weakness, sensory deficits, communication impairments. This leads you to determine what your main problems are and what your evidence-based treatment strategy should be. All goal setting does still need to occur with consideration of the person's environmental and personal factors, such as their home environment, social supports, their perspectives and emotions. So in summary, goals set in rehab should be meaningful, specific and challenging. They should include positive goal statements, and you should include short and long-term goals in the goal setting process. The next stage of the framework focuses on action planning. When we talk about action plans, we need to consider staff action plans as well as action plans for the person receiving care. Staff commonly have their own actions to complete to enact the treatment plan, and these can be things you need to get done, like doing an assessment or completing a home visit. But a person should also have their own actions to enhance their autonomy, and these actions should be something they could do independently or with some support, but something they have some control and ownership over. It could be things like homework or using a diary or doing a home exercise program. Actions for individuals need to be defined in their own words. They need to consider the person's environment. And we also need to consider how confident the person is that they can actually undertake those actions. So a rough guide is that people should be about 75% confident to undertake their actions. You should try and use visual aids to record your actions, and make sure you use that resource in each session to refer back to. There also might be quite a lot of actions that somebody needs to complete, so making sure you prioritise between 3 and 5 actions that are going to have the most impact will be helpful. So when you're using the ICF as the clinical reasoning framework, the action plans are set to address the major problems. Measuring performance during your action plan is also really important as a way of providing feedback. And measuring performance can include things such as measuring the repetitions of practice, using time trials or distance. And these measurements help you to monitor effectiveness, but also help you to evaluate the outcome of goal achievement. So goal setting can also then be used during your action plan to enhance adherence or engagement to the program. And for stroke survivors, where intensity of therapy is really important, goal-oriented instructions can also enhance an individual's performance. So a study by Tessa Hillig and colleagues found that using goal-oriented instructions can increase the amount of practice for stroke survivors. They found that stroke survivors perform more when they're given a target and when the instruction actually includes a goal. And some of you who've probably followed some of the StrokeEd lectures and presentations in the past may have seen this study presented previously. In this study, patients were given different instructions over a period of days. Firstly, they were instructed to do some exercise. Secondly, they were instructed to do that exercise 25 times. And then they were instructed to do it 25 times as fast as they can. And on the final day, they were instructed to do it 25 times as fast as they can, aim for their personal best. And they were given lots of verbal encouragement on that time as well. And you'll see here on the right-hand side of the screen that all goal-oriented instructions actually resulted in a significant increase in performance from the stroke survivor from baseline. And then there was also a significant difference between instruction A and C as well. So adding more goal orientation into the instruction improved that as well. So once you've established your action plan, it's important to consider any barriers that may prevent the person from completing the action plan. And then coping plans are a way of setting up successful action plans. So if a person doesn't complete their action plan, they're actually less likely to progress towards goal achievement. And a coping plan should be able to increase someone's confidence to complete their action plan. A coping plan should be established for each barrier that's identified to completing the action plan. Coping plans should be described in the person's own language. And if you're using a formal confidence rating scale, you should see an increase in the person's confidence to complete their actions once you've established some coping plans. So looking at a couple of examples, if your action, say, is to brush your teeth every morning, but the barrier identified is that the person has poor memory and is not remembering to brush their teeth, then a suitable and simple coping plan is something like setting up a phone alarm each day to remind them to brush their teeth. And again, if a patient's action has been identified as speaking to the family every evening on the phone to practice their clear speech strategies, but they actually have some difficulty dialing the number because of their hand function, then setting up something simple like voice control on the mobile phone will ensure that the action is more likely to be completed. So action planning phase should incorporate both staff and individual action plans, as well as identifying any barriers to action plan completion and establish coping plans to support these. And I might pause there again, Simone, and just check in and see if there's any questions or anything to address.
Yes, we've got a few requests for advice, Amanda, and a couple of questions.
Yep.
So the first one is asking about particularly when people have cognitive problems and yes, you're wanting to involve the family, and some of those processes have been very difficult during COVID. Do you have any suggestions?
Yes, I think we've all found that impacting our rehab over the last couple of years, haven't we? I think in terms of involving family, we've really tried to pick up on using the telehealth devices and trying to facilitate sessions that way where they haven't been able to attend to actually come to, say, a family meeting or a goal setting meeting. That's probably one of the biggest things that we've used to try and bridge that gap. Then also having smaller groups of people meeting with the family and the person who's receiving care together. I think it is quite challenging. There are a few applications out there and things that you can use to support goal setting, but nothing that kind of really fits the whole holistic process in terms of using web-based platforms and things as well. So yes, telehealth is probably the best way, or Zoom or that sort of thing to involve families.
Yeah. There's a request for advice, which is about when working with people who are palliative or have degenerative conditions, and if they've kind of given up and don't want to engage, do you have any advice in those circumstances?
Yeah, I think obviously that's quite a challenging situation, and it really should be guided by the person that you are working with and what they're wanting to achieve. I think if they're giving up and they're not feeling like they can make any progress, then I think it's really probably focusing in on what's most important for them at this moment in time, and where they want to spend their time is probably the most important aspect to try and help facilitate some sort of positive goal achievement for those people. They will still have things places they might want to go, people they might want to spend time with, even if they do have a shorter prognosis. And we can still find ways of facilitating that kind of goal achievement. But yeah, I think focusing really in on what it is that they want at this point in time is probably the most important thing.
Yeah. And also a request for advice when people have dream goals that they're not likely to achieve. For example, return to driving, if that's not perceived as realistic, I guess.
Yes, and I think like I'll point back to some of the literature that's been developed and it's come from people's perspectives and experiences of rehab. And again, they have stated really that whether or not that goal is actually achievable, it is still something that might motivate them to move forward. I think we have no right, I guess, to take away that goal from somebody, but we can advise them and give them information and support on alternative ways to perhaps achieve that goal. So I think you could employ some coaching skills and talk to that person about why it is they might want to return to driving. So what is it about driving that's important? Is it getting from A to B? In which case you can explore other options that might help that goal to be achieved sooner. Or is it more of a leisure activity, and could that be achieved in a different way? Could you sit in a car to go on a drive with a volunteer driver up through the hills? Or it depends why is driving important, I guess, to that individual. I think that's probably the key to find out, because then I think you can then help them reframe and find other ways of achieving it. Or yeah, that's probably what I would suggest, I guess, asking them why it's important.
Yeah. And the last one is a question about if you have a sort of a recommended number of short-term and long-term goals.
There's nothing hard and fast to say you should only do this or that. Generally, in our research, we have been focusing on around 3 to 5 goals as being sort of feasible. I think feedback, I think you can also ask the person that you're working with, because I think they'll tell you as well what is becoming a bit too overwhelming and what it is that they need to see the steps along the way. So it might be that you start off with these 3 or 4 and then you explain that there's going to be a few more from the short-term goals before you hit that long-term goal. But I guess it's really what's manageable for the person to keep in their head and focus on, I guess. So generally, in my experience, between 3 and 5 is sort of maximum. But again, I think you need to talk to the person that you're working with, and they might find that more steps in the process gives them a clearer understanding of recovery.
Okay, I think there might be some more coming up after, but maybe if we continue and then we'll come back to the other questions.
Okay. Thank you. Right, so the next phase in the goal setting and action planning framework is really looking at taking action. So a person needs to carry out their action plan either independently with supervision or assistance. It's good if they can record their actions, because this will assist you in evaluating. You should be providing regular encouragement and seek to support a family and friends as you need. Make sure you're checking in regularly as well while that person is actually taking the action. The final stage then looks at the appraisal, feedback, and goal progress review. So when you're reviewing goals, it's firstly important to review whether the action plan was completed and to what level. If action plans aren't completed, you're not likely to get a lot of goal progress. You might find there were some unidentified barriers to completion of the action plan, and you might need to develop another coping plan and try again. And then you want to evaluate whether goals have been achieved, not achieved, or if they're still progressing towards that. If they're not achieved or they're still progressing, they might need to find an alternative way to achieve that goal. You might need to change some of your action plans, or you might just need to give them a little bit more time. If goals have been achieved, people might be then ready to set a new goal. But at any point in the process, remember that people can choose to de-invest in a goal if it's no longer important to them. That's really important to remember. So an important aspect I thought I'd touch on when considering reviewing goal progress is the concept of using rating scales. So some people find using rating scales to rate their performance difficult. If you're finding challenges using rating scales, I'd suggest trying a smaller scale, highlighting the anchors and using consistent descriptors. So 0 equals not confident at all, 10 equals very confident. So making sure you consistently highlight the ends of the scale. You can try and highlight 2 choices and then refine the scale. So if you used a 5-point scale, for example, you could ask someone, are they confident or not confident? And if they said they were confident, you could then say, are you somewhat confident or very confident? So trying to help go through the scale by limiting to 2 choices can be quite useful. But make sure you do keep the positive and negative ends of scale ratings at the same end to prevent people getting confused. And make sure you think about whether or not it's words, faces, or numbers that the person responds best to, and use a combination if you need to. So everyone's usually quite keen on how to measure goal setting, so we'll touch on this quickly now. But the first thing I want people to ask themselves is, why are you wanting to measure goal setting? Is it for a person's feedback and review? Is it to review a service, or is it to report on a service? And this will help you decide if you need a patient-reported outcome measure, a staff-reported measure, or an experience measure, for example. I want to highlight a few common goal-setting tools and measurements now, and which aspects of holistic goal-setting practice they cover. This isn't going to be an exhaustive list, but some of the more common goal-setting measures. So firstly, the Canadian Occupational Performance Measure. So this is a tool that's person-centered and helps people to prioritise everyday issues. It helps support the goal negotiation phase and the appraisal, feedback and review phase. It can be used as an outcome measure. It's available online and on paper format. It has aphasia-friendly versions. And this is what it looks like here. You'll see it focuses on areas of self-care, productivity such as work and household management, and a person's leisure activities. These areas get weighted for importance by the person undergoing the assessment. And then they also rate their performance and satisfaction currently with each of those areas and after a period of treatment. And there's some minimal clinically important differences associated with the use of this measure also. The role checklist is another tool that can be used in the goal negotiation phase. It really allows people to identify roles that they had, that they have, and that they want to be in the future, and helps you to prioritise your the focus of your goal negotiation. The Rivermead Life Goals Questionnaire is a similar questionnaire. It's a 9-point questionnaire to identify how important each area of life is to an individual to help you focus that goal negotiation. And the Occupational Gaps Questionnaire is another one to support goal negotiation, but it's focused mostly on instrumental activities of daily living. So it's often more useful in like a community or day rehab setting. Talking mats are another option, and this is a communication tool that can support goal negotiation. This has been designed on the ICF framework and allows people to express their views about what things they enjoy and what things they don't enjoy or that aren't important to them. It does come in a hard copy version, but there's also an online version and online training available as well. Goal attainment scaling is probably something many of you have heard of. It's quite a popular tool. It's really been designed and supports setting of specific goals and the appraisal and review process. So goals in this tool are weighted for importance and ranked at 5 different levels. The one thing to note and be just cautious of is that it can be a little bit of subjective of this tool can be subjective, to a clinician's expectation of outcome. So it does rely on the clinicians and the people that there's goal setting with to predict an expected outcome from treatment. The patient-specific functional scale is a very quick to administer scale. It's an 11-point rating scale where people rate their performance of a particular activity. And there are minimal detectable changes that have been identified for this measure as well. Finally, goal management training is actually a tool that supports goal setting and action planning. It's structured and designed for people who have executive functioning deficits following brain injury. And the kits can be purchased online and they do require a level of training. The strategies included in the goal management training program can actually be used both as individual and or group sessions as well. And if you're interested in looking at these particular measures in more detail, I'd recommend you have a look at the Shirley Ryan Ability Lab, who now hosts the Rehab Measures database. And they highlight the evidence for each of these tools, the relevant population groups, and any minimal clinically important differences, and often will provide you a link directly to the tool. So following the action plan being taken, we then appraise those actions and see if they've been completed. You can use measurement to support the delivery of feedback and review, and you can discuss the goal progress. And so I've obviously only very briefly touched on those goal setting measures and tools, but what I would suggest you do is go away and look at each individual one if you're thinking about looking at what you want to implement in clinical practice, and just be mindful of which aspects of the goal setting process they actually support, because you're going to need to potentially introduce other things in your process to make sure you're covering off on that full goal setting and action planning framework process. Now I can pause again there, Simone. I'm conscious of the time, obviously, but wanted to spend probably about 5 or 10 minutes going through some of the barriers and enablers. But if there's anything else that you think we should answer in the Q&A, I'm happy to do that now.
Yeah, there are quite a few questions. Some requests for advice again. The first is how to be patient focused if you're working with somebody who really cannot identify goals themselves due to their cognitive impairment.
Yeah, I think this is probably the way I look at this is that you can be as person-centered as you can with what you've got available and with what that person can and can't add. And I tend to think of it more as a spectrum of people being able to be self-directive. So if you think about, you've got some people who can be very self-directive, can really drive their own recovery, rehab, know very clearly what it is they want to achieve. But as you go down that spectrum, people have voiced that they need different levels of support from clinicians to participate. So you need to try and access all the tools that you have. So you need to try and include family and friends to support. Try, I guess, get to know that person and who they were beforehand. Because these are the ways that you can, I guess, direct it to the most person-centered approach. You can't, not everyone can actually fully participate and actually tell you what they need to, what they want. So you have to rely on those support networks as much as possible, but exploring, who that person was before, what's important to them and their family. Those sorts of things are the most important strategies you can do to try and help set some more person-centered goals.
That might partially answer this question, which is around how much time you dedicate to goal setting and how you identify who needs a goal setting meeting.
And I think this has also been really challenging. Some of the literature actually talks about trying to have goal setting meetings with the people who are receiving rehab together. And I think that one study found that it took them up to almost 4 hours more per week to actually incorporate the people receiving rehab into the goal setting discussions. And this might lead into some of these barriers as well, because clinicians have also found it quite challenging having complex team discussions with the person receiving rehab care present, and trying to balance some of the differences there. I think, again, you need to know why you're goal setting and how it's going to impact somebody's outcome, and that'll help guide you with how much time you're going to spend on that. But I think we need to spend more time. I don't think we spend enough time with the people that we're working with to try and establish what it is that they want. And I think the more that they can understand it and come and know where they're heading and how they're going to get there, probably the more engagement you're going to get from somebody as well.
And this is maybe slightly related to that too, but it's really asking if you ever find it difficult explaining why people need to achieve the short-term goals before getting to the long-term.
Yeah, I think, I think visuals is really great for this kind of thing. So often we will use sort of like a staircase type approach, and really making sure that you actually have something written down, and just keep reiterating it. So if you're working on a task that involves just standing up, and the person's goal is to run around the block or go back to running on the beach, for example, you just need to constantly be reiterating that in your treatment as well. So remember, this is going to help you control your knee and get your strength back in your leg, so that once you can step, then you can step, on a hard surface, and then you'll be able to do it more on the soft surface and be able to do it on the beach. And that wasn't the best example, but each time you go through your treatment sessions, if you're constantly linking that back and reminding them that this is what it's important for, I think that's really helpful. And yeah, like I said, the staircase approach to the goals is quite good for some people. And also making sure you measure and show people, I think, that improvement over time. So when you can actually say, look, this task that you might not see as related now has meant that you can do this a lot better already. So you're already, say, walking faster, for example, because you're doing this smaller task that's important.
There are a few more questions, but I think maybe we should just continue with the presentation and come back to them at the end. Thank you.
Yeah, great. Thanks, Simone. So I will start to touch briefly now just on some common barriers and enablers to implementing goal setting. And we've already, just in that discussion there, started to highlight a few. Sarah Plant and colleagues did a systematic review and meta-analysis. And she looked at this from the UK. They looked at barriers and enablers to implementing goal setting across rehab settings. And probably the biggest barrier they first found, and this is something we've sort of briefly touched on now, is when there's differences between the perspectives of the person receiving care and the staff in relation to what goals should be set. So once again, people often want to include their hopes and aspirations and the long-term goals. And as we saw previously, clinicians tend to stick to short-term physical functioning goals, and they allow only a conservative estimate of progress. I think another point that's interesting to reflect on as well is that there's been some studies that have actually explored stroke survivors' perspectives of their progress, and found that often the stroke survivor is always going to be reflecting on their progress in relation to their pre-morbid status. So they're looking at themselves compared to pre-stroke, whereas us as clinicians are often looking at the patient's progress compared to directly after their stroke. So we'll sometimes have a lot bigger vision, I guess, of their progress than maybe what they do. So I think it's just important to remember that that's often what people are comparing themselves to. The other things that have been challenges, as we've just talked through a couple, are people's personal factors. So their level of cognition and communication, their mood, and their ability to participate. And clinician-related barriers as well. So our expectations of a person's recovery, our worry about avoiding disappointment, and the challenges that clinicians have had in managing team discussions with people present have also been identified as major barriers, and that you require skills to really be able to manage those team discussions and facilitate that well. Finally, organisational barriers have presented a concern for many clinicians, and we all struggle with things like shift working, staff turnover, and pressures to continue with competing priorities like discharge planning and things. However, there are some upsides. So there are some enablers to implementing person-centred goal setting that we can try and enhance in our practice. And firstly, we talk about tailoring goal setting processes to persons' preferences. So like we've talked about, some people really find the long-term ambitious goal motivating. Some people do find it overwhelming though. So really just making sure you tailor what it is that person's wanting to focus on and how big a picture they want to be thinking. Many people also don't really want to prioritise their goals because they actually feel that all their goals should be priorities. And as we've seen in some of that literature and we touched on before, certain people will need more support to participate in the process of goal setting. And this is especially important in those early stages of stroke recovery, where they've found that the stroke survivor themselves actually have identified they want a little bit more support in those early phases to help set goals. Making sure we include education and training is really important, and communicating both in written aphasia-friendly material, including things such as a key worker role has been identified as an enabler of person-centred goal-setting practice. And I think the benefit of this in my studies I've found is that people have a dedicated role and it's expected that they sit down and spend time with the person. And that at a team level is an expected part of the process. Family member involvement has also been an enabler for most people undergoing rehab. However, there are some instances where family members have been seen as disruptive if they've got their own agendas. So again, really go back to considering tailoring that goal setting process. And other facilitators to implementing the goal setting include having sufficient resources like time, expertise, and making sure you've got someone with skills to effectively chair team meetings. So a few suggestions if you're looking at implementing change within a team. Firstly, I'd really suggest you consider embedding changes into existing processes where you can. So modify or change a process before you try and introduce something new. Do tailor the evidence to your specific context, and ensure you set up a really well-defined implementation plan. So make sure that everyone's very clear about who's going to do what, when, where, and how. And this will help to create expectations and allocate roles among team members for implementing that change. You should also ensure that you have support from team leaders within your service, and that the team as a whole actually agree that the change is a priority. I would suggest considering using a facilitator model or a champion to help drive the change. There was one study that actually reviewed practice facilitation in GP clinics, and they found that GPs were actually 2.5 times more likely to implement recommended guidelines when they were supported by a facilitator. So Jill Harvey and Alison Kitson have published a facilitation guide for implementing evidence-based practice in healthcare, and that's based on the IPARIS framework. In that model, they talk about the importance of the facilitator role, but also the actual foundational skills that facilitators should have. Process mapping exercises are really useful to map, say, the current stroke survivor's journey and actually discuss within the team how the intervention will be implemented along the journey. You can then identify where things might go wrong before you start, And lo and behold, you can all set yourselves up a coping plan. Try using audit and feedback to implement change. So audit and feedback's been found really useful when it's delivered by a colleague, if your base performance is quite low, if it's provided more than once, if it's both written and verbal, but also most importantly, that an action plan is created from the audit and feedback process. And there's a Cochrane review that I've highlighted there as well about audit and feedback if you're interested in that. If you're looking at implementing change as an individual, I'd certainly suggest you focus on your individual skills in promoting shared decision making. And as I mentioned before, using video analysis to self-reflect on your practice and language is probably one of the most valuable things you can do. And make sure you are including all aspects of goal negotiation, goal setting, action planning, feedback, and review in your clinical practice. There's a few research papers here that I'd recommend reviewing about shared decision making and things that facilitate or impede the process. And so there's a few practical strategies within there as well that you can implement. So these were the resources I was just going to highlight. So the goal setting and action planning framework. So this link here is to the actual training for the goal setting and action planning framework that we've highlighted here today. And that was developed by Leslie Scobie and colleagues. The Queensland Statewide Rehab Network. So this is the project that I've been working on here in Queensland. Our resources are all available online, and we have resources targeted both to people receiving rehab as well as to clinicians working in rehab. And most of them we have tried to design to mean that they can be tailored to different services and settings. The Agency for Clinical Innovation have developed a really good rehab goal training workbook. And the Western Australian Training in Subacute Care, or TRACS team, have also developed some online goal setting education tools, which are available on that link also. So the take home messages for today, I think rehabilitation teams should really be striving towards interdisciplinary goal setting. We should be using a holistic framework to ensure that goal setting, action planning, feedback, and review occur in the process. You really need to practice the skills that are required for shared decision making and ensure people's goals are meaningful to them, specific and challenging. And don't forget to allow room for that dream goal. We'll highlight maybe a few pages of references as we go to answer any last questions.
There's a great comment here about how goals for discharge are often short-term clinician-led goals, and that those goals can have an influence on who gets community rehab. And so it's again asking for advice on whether you have any tips for how dream goals can be used to support onward referrals and to inform the aims of community rehab teams.
Yeah, I think it is common for the goals to be short-term and focused on physical functioning with a health services focus on trying to discharge people from hospital. But I think you can still, sometimes those goals are perfectly meaningful for the person as well, because I guess 9 times out of 10, if you walk around the rehab unit and you talk to people in hospital, the first thing they want to do is get home. So it's not to say those goals aren't meaningful either. But I think that the NDIS offers us a great platform as well in terms of trying to be able to build in some dream and long-term goals and have a plan for how they can be achieved in the community. I think that's been a fabulous addition to our national healthcare, or for people who are wanting to continue to progress goals in the community. I think that, I guess, if there are some tangible goals that you can work towards the dream goal, highlighting that for the follow-on community rehab services could be useful as well. But certainly I think a lot of what we can rely on is through the NDIS as well.
And just a note for overseas listeners that the NDIS is an Australian, it's the National Disability Insurance Scheme. So it's a system under which people with disability can continue to access services. with sort of a prescribed amount of money. There's a request here, Amanda, if you could go back to show the shared decision-making papers before we finish, so that people can have a look at those. But I think considering the time, we will finish up there. And thank you very, very much for your fantastic lecture with such fantastic advice to everybody. It's been really an amazing overview and very, very beautifully and thoughtfully presented. So thank you very much. We've got a lot of thank yous coming to you through the chat function there, Amanda. And if people still have some burning questions that we haven't got to, certainly feel free to send them through the StrokeEd, the info@StrokeEd email, and we can pass messages on to Amanda. But I think we'll say thank you very much. And and somebody said, could you flick to the next slide of resources, please?
Yeah, no problem. Thank you very much for the opportunity to present today. It's obviously a huge topic, and yes, I could probably, as you can tell, I can probably talk about it for days.
There's a nice comment here saying, I've been worried to allow patients to dream big. So that's a very big take-home message.
Yeah,
yes, I think that's a very, very important message.
Great.
Thank you very much. And thank you to all the attendees. Just also to let people know that the recording will sit on the StrokeEd website. So if there's any bits of it that you want to go back to, you can go to the StrokeEd website and go to the resource section and look for the recorded lectures. Thank you very much. We'll say good night to everybody. Thank you.
Thanks, man.